Hello everyone, welcome to my YouTube channel. So I will be looking at one of the questions that someone sent me regarding American Society for Clinical Pathology exam question. I will try to provide recommendation or maybe possible answers, just to get us to think along what I think that each of the questions may be indicating. So before we continue, my name is Dr. Emmanuel. I'm a biomedical scientist and I'm also a lecturer in biomedical science here in the United Kingdom. So let's get into this, okay? Now, this person, I think this was a question that the person sent to me, and this is actually in numbers. I have 3 questions, but this will be the first one I'll make, then I'll make the subsequent ones as well. This person has shown me this question, and I think they've been asked, consider the following ABO typing result, and then underneath it you're going to see additional test that was performed using the patient serum. So, and the question was then, what should be done? What should be done? So I would try to provide recommendation what I think that can be done, because they've given us options already anyway. But I feel that it is important that in addition to just try to find out the correct answer, that we understand what this actually meant, okay? So if you look at this briefly, let me see if I can get my pointer. If you look at this, you're going to see that this is a kind of forward group because this is a patient cells, okay? I have told us many times, that when we are measuring something on the cells, that is forward, that is direct. But look at this plate, this is indirect or reverse, okay? Because what you are measuring is the patient serum, okay? Or it can be patient plasma. So if you look at this, obviously they didn't give us a full ABO grouping. What they've done was just to show anti-A, anti-B, okay? Remember, these are kind of anti-sera A, okay? These are commercially prepared antibody, okay? So that would then help to determine the type of antigen the patient has. For example, if the patient is blood group A, you would expect the person to bind with this anti-A, okay? Because the blood group A has antigen A, and if the person is blood group B, you would expect the breast cell to bind to this very anti-B because the person has antigen B. And obviously, if the person has blood group A and B, if the person is blood group A and B, that means the person has antigen A and antigen B. That means this place and this place will be positive. If the person is blood group O, you would not expect anything here because blood group O does not have both antigen A and antigen B, okay? Right, so if you look at this forward grouping, you will see that anti-A is positive and anti-B is what? Negative. So obviously, this is already suggesting that this person has antigen A only. And if this person has antigen A only, is already suggesting that this person is blood group A. Okay, now remember that in blood group A, the person should have antibody B. Okay, now let that come to the reverse grouping. In this reverse group, you're going to see there is A1 cells, there is B cells. By the way, so the same way that this forward group, this anti-A, anti-B are commercially prepared antibody to detect the patient red cell antigen. So these places are commercially prepared cells, okay, to detect the antibody the patient has in the plasma, okay, so or serum. So that's why serum is used here, okay? So this commercially prepared, A1 cells, which is blood group A, by the way. So we can have A1 cells, we can have A2 cells, as the case may be. So the one that is more predominant is A1, by the way. So that's why most times they use A1 cells. I think study have shown that A2 cells is about 1% or less than 1%. So that's why they make use of A1 cells, okay? Right, okay. Now, but then you have B cells. So if you look at this is positive on B cells, which is confirming that this person is blood group A because it has antigen A and antibody B. However, there's a problem here, which now becomes ABO discrepancy. And this discrepancy is on the side of the plasma, is on the side of the serum rather, is on the side of the reverse grouping, because the A1 cell is positive. And this A1 cell being positive has nullified what we are seeing here, because the only place we can see, because this A1 cell being positive means that this patient has antibody A1, and B cells being positive obviously means that this person has antibody B. And like I said, this antibody B confirms this blood group A because blood group A has antigen A and antibody B. But seeing this very A1 cell positive here is saying something different, because it's saying that this person has antibody A and B. Okay, and if that is the case, the blood group that you have is supposed to be blood group O. And if that is the case, then this place should not be positive, because blood group O does not have antigen A, does not have antigen B. So the presence of this very +1 of this A1 cell is already causing an ABO discrepancy here, and that then need to be investigated. So, but like I've said, a good biomedical scientist looking at this already will begin to think that this is blood group A. This is blood group A patient, okay? What this person now needs to investigate, why are we having positive in this very A1 cell? And I can also mention that it's also important to know that this A1 cell's reactions is not as strong as this very B. So this is a weak reaction, if that makes sense, okay? So maybe we don't know what may be going on here, okay? In fact, I have been looking at it. There are many things I'm going to be showing us before I go into the answer. But one other thing you might consider, remember that the plasma contains antibodies, okay? So when we give somebody platelets, because the platelet is a mass in the plasma, okay, so that contains antibody. And of course, when we give FFP or we give cryoprecipitate, is produced from the plasma as well. So I've been thinking, is there any possibility that this person, that is blood group A, has been given maybe something like maybe blood group O platelet, or maybe blood group O FFP, or maybe blood group O cryoprecipitate, and because of that introduction of that very plasma, which perhaps has introduced this very antibody A in the patient. And if that is the case, that is a huge ABO incompatibility, okay? Because someone who is blood group A should not be given, FFP or cryo or platelet that is blood group O, except if it is high titer negative, okay? But like I've said, that's one of the things I'm thinking. Now, another thing to think is that could it be that for some reason this person was given a plasma or platelet or FFP that is blood group B, and because the person is blood group B has antibody A, is it possible that that antibody A that blood group B patient FFP or cryo or platelets has been transfused to this very blood group A patient? Maybe that's why we are seeing this very weak reaction. And again, if that is the case, this is a huge ABO incompatibility, and that should not have happened. But whichever way, that needs to be investigated. So one thing is certain here from what we consider, this person is blood group A, because it's had antigen A strong reaction, the reverse group showed B cell strong reaction. So it's already strongly indicating that this is a blood group A patient. But this A1 cell positive here is making a discrepancy, is an interference, which we need to find out why are we getting such results. Anyway, before I say many other things, so now they did additional tests here. Stay with me. They did additional tests here. It was performed. So this additional test, look at this. They did a screening cells, okay, which is a kind of indirect antiglobulin test. Remember? So they did a screening cell which has cell 1, cell 2, and also they did auto control. That means the patient cell against the patient plasma. Then something interesting began to happen here, because we now find out that this IS or room temperature, so this one was done maybe at 37, this one was done at room temperature, okay? So we now notice that there's a weak reaction at 37, okay? Stay with me, okay? But then at room temperature, it becomes, even though it's weak, but a little bit stronger compared to that of the 37 degree, okay? But what is also important here is that the presence of this very reaction here in cell 1 and cell 2, suggests that there is an antibody somehow, okay? So what we don't, it suggests that maybe it's an allo antibody, okay? Whether it is here, could be suggestive of maybe warm antibody, here could be suggestive of maybe a cold antibody, okay, as the case may be. But again, we cannot turn a blind eye on the fact that there is auto control, which is also positive. In fact, the same reaction with this very cell 1 and cell 2. Maybe there's an interference coming from the auto, because this auto control is the patient cells against the patient plasma. Maybe we're dealing with auto antibody here. So what exactly are we looking at? And these are the possible things we're going to look at before we can be able to answer this question, because the question says what should be done, okay? So let us explore many things before we can come to what exactly that can be done. I hope that makes sense. Yeah, let's continue. So now you're going to see that So first of all, let's look at this. It's, patient cells, like I've said, is anti-A positive and anti-B negative, which obviously suggests that this is blood group A. I'd already said that, okay? Now, another thing we can consider is the fact that I've also mentioned that the patient serum, unfortunately, is giving A1 cell positive, and this is obviously an ABO incompatibility. That's ABO discrepancy, okay? So that needs to be investigated, okay? Now, remember, the idea is to come to the answer. So that is why I began to ask myself, we now need to query, is it ABO plasma incompatibility? Like I had mentioned, is it possible that we have this patient that is blood group A? Has the person been introduced, exposed to maybe D plasma or O plasma that perhaps has introduced this very anti-A somehow in the system of this person? That's what we need to query. I know the answer to this question, but I feel like we need to think around sciences around this before we can arrive to what we are thinking. So far, you can see that what is common here is that there's ABO incompatibility in terms of blood transfusion by plasma or platelet, as the case may be, or perhaps something like due to this auto control, we may be looking at, is there auto antibody that we're dealing with, okay? So let's continue with that first. So now the additional test that I've done, which is this one, suggestive of what there can be what auto antibody. I'd already mentioned it, okay? Now, why did I say cold or warm? I said cold because this is a room temperature, okay, and it is stronger. Then warm, this is also 37. So what is really going on here? It can be suggested that there can be auto-antibody. In fact, this is important that we note that, okay? Now, let's continue before we get into that. So you are going to see that the final outcome of what this is likely to be is likely to be maybe, because of what we're looking at, is possibly that this is going to be auto-antibody, okay, that may be interfering on this very reverse group. So that is my suggestion here, that perhaps, because this is very weak, and this weak reaction as well, this weak reaction is also expressed even in this place, because even +2 is not that very strong, okay? It's still a weak reaction, okay? But I think that what is going on here is that this auto-antibody perhaps may be stronger at room temperature, but it is suggested that this very auto-antibody that we're seeing on this, because of this auto-control, I'm thinking that this is an auto-antibody that has interfered on the very cell 1, interfered on the very cell 2, and obviously being seen on the auto-control. And these very auto-antibodies, I think, is what is interfering here. That is my own suggestion, because I think that interference is producing a non-specific agglutination or reaction, okay, or binding, as the case you might say it, okay? So that is my, final outcome, what I'm thinking, that what we're seeing here can be due to auto-antibody interfering with that. I hope that makes sense. So let's continue. Now, what if we are thinking that is auto-antibody? Now, we need to now ask ourselves, how do we then investigate this? We can investigate this by looking at direct antiglobulin tests, because that will help to see the antibody binding on the surface of the red blood cell, which can be, help us to know whether it is auto-antibody. Now, obviously, if you think it's auto-antibody, especially in terms of maybe auto-antibody like based on cold agglutination, as the case may be, cold agglutinin, that's the word, cold agglutinin. So if you think it's due to cold agglutinin, which explain why this reaction is stronger at the room temperature here, you might decide, okay, let's pre-warm it up to 37 and repeat the thing again. Perhaps it will help. And of course, if we think, okay, that is actually what it is, okay, it is a cold, antibody, or, or maybe whether it is warm antibody, but it is auto-antibody, we may need to consider to now elute, to kind of wash up, to kind of remove that very auto-antibody. And once that is removed, it can help, to provide clarity on the antibody, that is antibody panel, that is antibody identification, okay? It will help to provide that very clarity, okay? So that I'm giving us some suggestion of what they are already giving here already. But these are some possible things we can consider. So far, what this is likely to be is to be due to what auto-antibody. It could also be due to maybe cold agglutinin, which is also a kind of autoimmune, okay? So let's continue. So now, to be able to answer this question, because this is a multiple choice question, MCQ, okay? So what then should be the answer? I think that what we need to do then is to go through each of the answers and then see what is likely to be. I've arranged it this way because I think it will help us to understand what is going on here. So first of all, you are going to see that when we say that they gave us the A option, say that in the A option, is saying that test serum. That means you should test. What should be done? Should we test the serum against a panel of group O cell? Should we test the serum against the panel of group O cell? Now, remember, like I told us previously on my video about the reason why we use O cells for the antibody screening and antibody panel, okay? So they don't have antigen A, they don't have antigen B. So should we not test the serum against a panel of group O cells? Now, this is unlikely. That's why I'm saying this. It is unlikely because that group O cell they are trying to tell you here is about antibody screening cells, okay, or maybe antibody cells, okay, antibody panel cells. So these O cells are what we use to prepare the antibody screening cells and antibody panel cells. So the reason why I said it's unlikely is that if it is allo antibody, okay, it should be obvious, and that allo antibody should not be interfering on the A1 cells. Remember that these very O cells does not have antigen A, does not have antigen B, so there shouldn't be any interference on this very A cell, A1 cell here. I mean, in terms of the if it was in terms of the antibody, okay. So this is unlikely because this very cell, this O cells, is mainly used to detect allo antibody. But in addition to that, even if you want to say, okay, let's forget about the allo antibody, let us use it to test, let's bring the patient sample, which is a serum of the patient, and test it against O cells, okay? Now, are you testing it against O cell for, what are you trying to find out, okay? If you find out that you take the patient serum against O cell, okay, that in itself is a kind of reverse kind of grouping, if that makes sense, okay? So now what that is going to show you, are you trying to find out whether the person is O cells, O blood group? If the person is O blood group, this place there should not be any reaction here, okay? Now, if the person is not blood group O, are you getting me? So what then are you trying to really find out, okay? So now, what should be done should not necessarily be to test against a panel of what? Panel of group O cells. Now, like I've told you, this panel of group O cells is for antibody panel. What antibody panel should be focusing on is IgG, not IgM. What this is talking about is IgM, if that makes sense. Remember that the essence of this very further grouping, the essence of this further testing is because of this discrepancy. So if we are going to test serum against a panel of group O cells, that is talking about screening cells or maybe antibody panel cells. And like I said on my previous video, these cells are used because blood group O does not have antigen A, does not have antigen B, okay? So we can only test the patient serum against panel group O cells if we are trying to find out a particular allo antibodies, okay? That is when it becomes necessary, okay? We don't use antibody panel in quote to find out autoantibody, as the case may be. In a case of autoantibody, you'll be surprised that it's going to react everywhere. You are going to get a pan reaction, pan reactive. So you are not going to be able to detect anything, as it were, okay? So that may not be the best idea on this occasion, okay? Yes, we are suspecting autoantibody, okay? If you do this, why? The only thing this may show you, obviously, if it is autoantibody, you may get a pan reaction. Obviously, like you're seeing here already, it's already a pan reactive everywhere. You may do the antibody panel, you still get a pan reaction everywhere. It still does not show you anything. What you need to be thinking now is this autoantibody, we need to investigate it, and we need to find out, is it a warm autoantibody or cold antibody? I hope that makes sense. Yeah, okay. Now, the neutralization also is not likely, is unlikely as well. Let me explain what I'm trying to say. They put this, in my own opinion, this and this, they are just opposite. So here you're looking at maybe mainly something like warm antibodies, but here something like cold antibodies, okay? So when we get a cold antibody like maybe anti-P1 or anti-LUEA, there are so many of them, maybe LUEB as the case may be, okay? So once you notice there is a cold antibody, so what you can do is that you can decide, you know what, let us neutralize that very cold antibody. Okay, so we use neutralization in a case of a suspected, certain antibody that are what cold antibody. And once we suspect a cold antibody, we can use neutralization to neutralize that very cold antibody. Again, that will not provide a further information on this. Stay with me. Now, we now go to the next point, which I think is yes. Okay. Now, my own opinion, C and D is what is likely to be. More likely to the first action supposed to be C. Perhaps later you can take action of the elution techniques. But let me explain what I mean. So this one is saying perform a serum type at 37. So what it means is that if we are suspected that this is a cold autoantibody, okay, and because this autoantibody seems to be stronger, if you see this, it seems to be stronger, at room temperature. Maybe if you can perform a serum type by at 37, where you have warmed the serum at 37, then repeat it. Maybe that can clear this. Okay, now that means you are suspecting that the antibody here is stronger at room temperature, is not strong at 37. Maybe if you warm the serum at 37, it's going to dislodge, kind of inactivate, okay, that very autoantibody in such a way that once the sample is still warm and you repeat this reverse group and repeat this very antibody screening, you'll be surprised that it's going to come out clear. Okay, because what it means that once that very cold antibody has been dislodged or inactivated due to pre-warming the sample at 37, that will not make this place perhaps is going to be negative, if that makes sense. Okay, and of course this place may be negative, that this place may still remain of course it will bring it to be what negative. Okay, so that is why I think that is the case. And that is why if you now think okay that is a case, you might not decide okay that means this is a cold antibody. Okay, this is a cold autoantibody. Maybe what we can do then is to kind of elute that very cold autoantibody, and that's then make elution techniques to be useful. So in my own opinion, if we are going to answer this question, I would suggest that the answer should be what C, because what we are suspecting here is autoantibody. And from the result we are getting here, we are feeling that the autoantibody is what is interfering in this very A1 cell, if that makes sense. Okay, now, and if that is the case as well, what it then means is that this autoantibody is also what is interfering in this very antibody screening cell, and of course is also positive. And we found out as well that this very autoantibody is stronger at room temperature, and that is why if we can raise the temperature up to 37 and repeat the test, maybe that will clear the very discrepancy both here and here. And of course, if that is the case, we can now do elution techniques. There is something else I'm going to say here, which I think may be useful as well when I get to the next video that I'm going to make. Now, let's look at this. If this person is blood group A, this person cannot be producing antibody A, if that makes sense. Okay, if he does produce that very antibody A, that is now autoantibody, if that makes sense. Okay, now if it is autoantibody, then that means that could explain the essence of the very interference we are seeing. Okay, if that makes sense. Or maybe there are other antibodies like we've mentioned, like this cold antibody that perhaps is interfering with this. Anyway, the answer to this is the fact that this is an autoantibody, and this autoantibody from this very antibody screening suggests that it is stronger at lower temperature than 37. Maybe if we can warm it up, warm the serum at 37, it can help us to clarify what is going on here. So the answer I will go with C. And obviously I don't know how if it is only one question you expected to answer, then it has to be C. But if you expected to answer more than one, then I'll go with C and D, because then after we have identified that, yeah, this is indeed an autoantibody, maybe cold autoantibody, we can now consider doing elution techniques to remove that. But you cannot talk about elution techniques if you've not identified first what you are dealing with. So we talk about elution techniques when we're looking at maybe something like autoantibody, like I'm trying to explain here. I hope that makes sense. Yeah. Okay. Thank you for listening. Let me know what you think about the video, and let me know if you do have any question. I'm more than happy to entertain that. And let me also say this: if you're already practicing and you have experience and you think that there's something that I'm missing, please feel free to also put it in the comment section, as it will also help the people who come across the video. There is something else I would like to mention. Please, can I ask you to like, share, subscribe. Make sure you subscribe. It's very, very important. And of course, feel free to contact Too Good Consultant Limited. Too Good Consultant Limited. We are here to always help. We are more than happy to support you when it comes to your interview preparation. We are more than happy to support you with your academic, okay? We are more than happy to support you with your career. So whichever way that you need our help, please feel free to contact us, okay? I hope that makes sense. Thank you very much, and I wish you all the best till I come back your way again. Bye-bye.